Hi, this is Dr. Bernstein with our April 2021 issue of Dr. Bernstein's Diabetes University. Before we answer questions, we're going to look at a few recent articles pertaining to diabetes. The first one relates to training in exercise training in non-diabetics. Small group of men and women. By small, I think there were 5 men and 6 women, or vice versa. And they tried overtraining them. That is, they didn't go into details in the report that I read. I read an abstract put out by the New England Journal of Medicine, but the actual report, which was in Cell Medicine, in 2021, and that's where the details of the exercises were. And what they claim is that they overworked this group of people and found that those who were overworked had higher blood sugars during exercise and lower blood sugars. In other words, a wider range of blood sugars while they were exercising. And they're recommending that people don't overdo it, but it's unclear to me what overdo it means. I've been recommending exercises slow exercises with fairly heavy weights that gradually tire out your muscles so you can't move, and that's when you stop. I might be wrong. Maybe what I'm recommending is causing poorer control of blood sugars during the exercise session. An article in the journal Diabetes in 2021 elucidating phase 1 and phase 2 insulin responses. We knew for a long time that phase 1 was a rapid response to a meal, and phase 2 was a slower response that happens later on in non-diabetics. And what they did was measure electrical potential in the pancreas on a micro scale, and they found that during phase 1, that is at the start of a meal, there was not only rapid release of insulin, but beta cells that were releasing insulin were acting in small groups. They detected this electrically with microelectrodes, and the motion of electric current corresponds to influx of calcium ions. When calcium goes into a cell, it enables the cell to export a product. In this case, it's insulin. And small groups of beta cells would participate in phase 1 response, whereas phase 2 response, the prolonged slow release of insulin, entailed many cells throughout the pancreas, much more universal for phase 2 response. So it's more details that are sort of interesting. Another study of the brains of type 1 diabetic children. Over the years, there have been many studies, and many endos, according to my patients, are telling people that I'm hand-picking articles, that the general effect of high blood sugars on brains probably shows studies both ways. If I had seen them, I would have picked them. if there were studies that showed that high blood sugars had no effect on the brain or had good effect on the brain. And it's just not turning out that way. We're getting study after study, and here's one from Diabetes Care in early 2021. Impact of type 1 diabetes in the developing brain in children, a longitudinal study. And again, this was not a large group of people, but what they did was they tracked kids over a number of years, looking at both MRI scans of the brain and testing IQ. And what they showed was that over time, the size of the brain compared to non-diabetics was diminished, and the IQs were lower. And they further correlated this with hemoglobin A1C, and the higher the A1C, which would mean the higher the blood sugars, the more damage to the brains. Certainly an important study. Now we're going to answer some questions, but before we start, I remind you that my answers are generic. I cannot possibly examine and get a full medical history on every patient who sends an inquiry in. And I therefore make guesses, and the guesses are meant to educate all the listeners, not necessarily solve the individual problem, because I can't get enough information to solve the problem. So these are guesses. If a finger prick tells me that my blood sugar is around 3.5 millimoles or 63 milligrams per deciliter, does that also reflect the concentration of glucose in my brain? And my answer is not necessarily. Certainly not if the blood sugar is changing rapidly. First of all, there's a blood-brain barrier where both glucose and insulin from the body have trouble getting into the brain. They get into the brain, but more slowly than into other cells of the body. So there's a time delay. And does the brain blood sugar level, does the brain glucose level eventually match that in the rest of the body? If blood sugar changes slowly, I'm not sure. But I guess the answer is probably. If blood sugar changed very slowly or was steady for an extended period of time. Dr. Bernstein discussed Dupuytren's contracture, which I have in both hands. I'm very interested in learning how to receive his combination topical treatment of DMSO and collagenase. Collagenase is an enzyme that dissolves collagen. And what we find in diabetes is that many proteins get glycated, just like glycated hemoglobin A1C. Glucose sticks to the hemoglobin in red cells. Glucose sticks to other proteins. And one of the longest lived proteins in the body is collagen. And if in the situation of Dupuytren's contractures, which is sort of a claw hand, usually starts with the fourth finger. The collagen in the flexor tendons on the palm of the hand gets glycated, the tendons get swollen, and eventually the fingers flex. Now, if you can break down the glycated collagen so that these tendons are no longer swollen, you can straighten out the fingers. And Sometimes the Dupuytren's contracture is accompanied by a big lump on the flexor tendon. Sometimes it could be the size of a 25 cent piece if you're dealing with American currency. And the standard treatment is for a hand surgeon to inject collagenase into the flexor tendon or into these lumps if the lumps occur. And they usually charge several $1,000s per injection, and you need a number of injections spread out over a course of many months. The solution that I came up with, which I've only had occasion to try on one person, was to mix 1 part of collagenase, which is very expensive, with 6 parts of DMSO, which is a solvent that goes through the skin and into the underlying tissues. So the collagenase is soluble in DMSO, and if this preparation is applied to the skin overlying the Dupuytren's contracture, it will soak through the skin with the collagenase, and over time, if you put it on 2 or 3 times a day, you could use an applicator brush like nail polish, and you put it on 2 or 3 times a day, and the swollen tendons do shrink, not in length, but in thickness. So I tried this on one person and it worked, and I certainly think that it might work on more than one person. Type 1 with an A1C of 4.8%. I managed to get this results with Novorapid, about 2 or 3 units per meal, and Tresiba, 7 to 11 units per day total. I want to use regular insulin because I think the results can be better, and you recommend it in your book. My doctors are saying it is not necessary because they're happy with the results. What should I do? Well, again, I'm just guessing, but I think it depends on your actual blood sugar fluctuations. An A1C of 4.8% is pretty close to normal, to non-diabetic. And if your blood sugar, let's say that an A1C of 4.8 corresponds to an average blood sugar of, let's say, 89 milligrams per deciliter. And if it's level at 89 milligrams per deciliter, that's pretty darn close to the 83 milligrams per deciliter that we seek as the target. But if your blood sugars are swinging, let's say going from 70 to 110, and averaging 89, maybe you would do better with the regular insulin. So I'd say that you look at your blood sugar swings, and if you're having swings that you don't like, point them out to the doctor. Don't just show the doctor the A1C, show him the range. That's my guess of an answer. I'm 21 years old and have type 1 since I was 7. Until around a few months ago, blood sugar used to be quite low, around 40s and 50s, and I would get a lot of black spots in my vision, and they would eventually go away over a few minutes after drinking liquid glucose. But ever since mid-2020, every time I go out in bright light, in a brightly lit environment, uh, usually when the sun is out, as soon as I see the sunlight would hit my eyes, I would see spots again, and a lot of them. I have visited my eye doctor multiple times, and after checking my eyes in various ways, they say that my eyes are clear and the blind spots will go away, and I should learn to live with them. What are these spots? How do I get rid of them? Good question, but I don't know the answer. I would say that one important thing to look at is what is your blood sugar when you're seeing the spots. Um, you may think that your blood sugar is not low, but do you check it? So that's the first most important thing, because yes, you can see spots with low blood sugar. I've seen sort of gray spots um, that were fairly large, but um, it's also possible to see spots that are uh, the size of a pinhead, even smaller, and are black. These can be red blood cells, but they wouldn't relate. Well, the only relation they would have to uh, bright daylight would be they might not be discernible if there are dimly lit objects in the background, but if you're looking at, say, a white screen and you have little red cells floating uh, in your vitreous humor of your eye, uh, you might not see them until you look against a clear, plain white screen. So that's a possibility. In any event, if this phenomenon is not accompanied by low blood sugars, I would say that you see a retinologist, not just an eye doctor, and he may want to do a test called ocular computer tomography. It's like a CT scan of the eyes, but it does not use um, X-rays. It uses visible uh, infrared light in the study. I've been following your recommendations for many years. I'm type 1 since my mid-30s, now late 40s. I was just wondering, what is the average insulin that is used by low carbers? I have read in the literature that's an average of 0.5 per kilogram. That seems a lot. I use 18 units of insulin in total. I'm just worried about the amount of exogenous insulin that I am using. Exogenous means amount that he's injecting. And as far as I can tell from looking at my non-obese patients, those that are not insulin resistant, and kids that are people who are not growing children, it looks like about 0.4 units per kilogram of body weight, which is pretty close to your 0.5, although it is a little bit lower. Now, I don't know your body weight, so I can't comment on whether you might be insulin resistant or not. I do know that people on ADA dietary guidelines, high carbohydrate diets, take much higher doses of insulin, especially if they're type 1s. My daughter is 12 years old with type 1 for 6 years. What would you say is the highest sustainable blood sugar without getting into DKA, diabetic ketoacidosis? Well, first of all, one must define diabetic ketoacidosis, which varies from doctor to doctor, from organization to organization, and from manufacturer to manufacturer. For example, there's a product on the market to treat type 2 diabetes, SGL2 antagonists, and these work by causing the kidneys to pee away slightly elevated blood sugars in the urine. And there's a warning, the manufacturer warning, watch out, this product may give you euglycemic diabetic ketoacidosis. Now, I don't think there is such a thing. Euglycemic means normal blood sugars, diabetic ketoacidosis. What they're meaning is that there are some ketones in the urine or in the blood. And whether this is harmful or not is a question mark, but I would not call it diabetic ketoacidosis because diabetic ketoacidosis involves dehydration, usually vomiting, and very high blood sugars. I would guess usually over 300 milligrams per deciliter, sometimes much higher. When I was diagnosed with diabetes, my blood sugar was 750, and I was perfectly conscious and rational, but I was thirsty and peeing a lot. And I was in this state for 2 months, peeing and drinking, before my parents sent me to a doctor. So one has to decide what is diabetic ketoacidosis. And if you're talking about the classic case where these kids lose consciousness and their lives are in jeopardy, I wouldn't be thinking about this for my daughter, that all I want to do is avoid DKA. I would want her not to have the brain damage that we discussed earlier, and I'd want her not to get the long-term complications of diabetes, which children can certainly get. Hi, Dr. B. I am 19 years old and have had type 1 diabetes for 14 years. I am planning to stop using my insulin pump and switch to insulin injections. However, since I have used the pump for many years prior to reading your book, I have developed scar tissue at my injection sites. The injection sites are on my butt, which you have mentioned as the best place for insulin injections. It's amazing that you're able to keep a pump catheter in your butt where you sit, and it's pressing on this catheter all the time. It's sort of amazing that you didn't cause problems with insulin flow. But anyway, is there any way to heal this scar tissue? I have been using Neosporin scar ointment, but it doesn't seem to work. My guess is that that's meant for wounds where you don't want the wound to turn into a scar when it heals. Does it work for that? I don't even know, but I doubt that it's going to work for this subcutaneous scar tissue. There are a lot of products out there on the internet, so I wanted to know what you think would work best. First of all, I would suggest that you talk to a dermatologist, and you might ask the dermatologist about the mixture of collagenase and DMSO that I just described. Would scar tissue caused by a foreign body be high in collagen? I don't know. So you might discuss this prior solution that I mentioned, collagenase, 1 part collagenase, 6 parts DMSO, applied to the area several times a day. See what the dermatologist thinks. Also, I would suggest that you give your injections in your belly and your hips if you've not been using these sites for the insulin pump. So that was an important question, because I'm sure that there are many pump users who want to switch to injections and are encountering the same problem. My wife, now 40 years old, was diagnosed with type 2 diabetes. Could Dr. Bernstein recommend potential steps for getting her periods back? She could try normalizing her blood sugar. She would have to read my book. That might or might not work. She should visit a reproductive endocrinologist who may have some suggestions that such as hormone treatment or other causes than the diabetes. For example, there's a benign tumor that's rare but not that rare called a prolactinoma that's usually benign but secretes a hormone that will enhance lactation but inhibit periods. So there could be some other cause of the loss of periods, so she should see a reproductive endocrinologist. I've been an insulin-dependent adult onset diabetic for 30 years. I'm now 66 years old. I am not on the Bernstein diet, but I do eat less than 40 grams of carb per day. I've exercised by swimming laps for most of these years as a diabetic, and only in the last 2 years has my blood sugar begun to rise excessively after swimming workouts of about 1,000 yards. I'm wondering, what is the root cause of the change? Root cause of this change might be especially since in earlier years I had to be more careful of my blood sugar dropping. Well, first of all, now that you're older, you might be swimming more slowly. And there's the old adage of Elliot P. Jocelyn that I must have mentioned dozens of times on my videos. He said, diabetics should not run a block for the bus. If they're going to run for the bus, they should run a mile. And the idea is that exercise can cause the production of stress hormones that raise blood sugar. And if you're going to exercise, it should be long enough and strenuous enough to bring the blood sugar down. So you may be swimming more slowly. You are type 2 diabetic. You may have been making more insulin in the early years, and you're making less insulin now. And you need a certain amount of insulin to prevent the blood sugar rise from the exercise. Now, if this is caused by stress hormones such as adrenaline, there's a possibility that taking a small dose of propranolol, which inhibits the production of adrenaline, which might raise blood sugar, it's a possibility, but you should first discuss it with a cardiologist at your age before taking this kind of medication, which can lower blood pressure. So that's a possibility, but you certainly have to check with a doctor. I'm 37 years old, type 1 diabetic from Slovenia, diagnosed 6 months ago. Question is, sometimes my blood sugar drops to 70 to 72, and I still feel fine. I start to feel signs of hypo only below 65 milligrams per deciliter. Are there any long-term risks of having blood sugar below target level of 83 for prolonged periods during the day or night? That's a very good question. I think that I've seen only 2 studies, maybe it's 3, of what are the blood sugars in large populations and how do the blood sugars correlate with mortality. And these studies are sources of my 83 target because they both showed a J curve. That is, lowest mortality, long-term mortality, at blood sugars of 83, rapidly higher mortality as blood sugars go up, but also slightly increased mortality as blood sugars go down. So it could be that if your blood sugars are most of the time around 65 rather than 83, the population statistics would indicate that long-term mortality is greater at 65. So I have to point that out as a possibility. Now, I'd certainly recommend that you get a Dexcom continuous glucose monitor that will warn you whenever your blood sugar drops below a target. I also would suggest that you use liquid glucose, as I do, to treat the low blood sugars. Also, that you find out what you can do to prevent the blood sugar from dropping, prevent it in advance. You're taking insulin. You should probably read my book to find out what you can do to prevent the lows. You mentioned that you started prescribing Verapamil to some of your patients. This medication is thought to protect beta cells from oxidative stress and help prolong the honeymoon period at the beginning of type 1 diabetes. I have easily found several studies and publications to support this hypothesis. Please tell us more about the results achieved by your patients taking Verapamil. Well, my problem is that these are kids who are growing, and all of the kids that I'm treating are growing rapidly, something which doesn't necessarily happen with people on the ADA regimen. But since they have close to normal blood sugars, they're growing rapidly, and the bigger they get, the more insulin they need. Furthermore, if they're making growth hormone, Growth hormone tends to raise blood sugar. So they're all requiring more insulin. But we do have evidence that they're still making insulin if we check C-peptide, which we occasionally do. But it's very hard to look at C-peptide levels because C-peptide levels in a non-diabetic depend upon what you ate and also upon your blood sugar. So there are lots of things that affect how much insulin you're making at a given moment. So it's very hard to tell if you're dealing with growing kids. Now, if you want to keep up on the research, you can search the internet as well as I can. In fact, you've clearly been doing it already, and you could see if there are any newer articles on the subject. I lost coverage, I guess insurance coverage, for Tresiba and or Levemir insulins. Insurance will only cover Lantus, which I refuse to use. The reason this person refuses to use Lantus, I'm sure, is because we mention in my book and also on my videos that that Lantus has 165 times the affinity for IGF-1 receptors than does human insulin. And IGF-1 receptors are present on cancer cells, and if they're stimulated, they can help cancer cells grow and proliferate. So that's probably the reason this person doesn't want Lantus. There's another reason for not wanting Lantus. It is an acidic insulin, and some people complain that it burns when they inject it. Other people complain that the injection site will be burning for many hours. Anyway, getting back to the question. I am contemplating using NPH instead of Tresiba. That's because of insurance. My last A1C was 4.6% 2 weeks ago, thanks to your book. How should I proceed with NPH? I know you don't recommend it in your book, but my options are quite limited. What's reasonable dose to begin NPH if my Tresiba need is 15 units a day? In theory, I would take a third of the Tresiba dose and give it 3 times a day, which would be every 8 hours. But just on the possibility that the NPH might be more effective, I'd lower that guess. I always maybe instead of taking 5 units 3 times a day, I might take 4 units or 3.5 units, see what happens to the blood sugars, and then raise the dose if necessary. That's all I could think of. It should be possible to get a special dispensation from your insurance company. It's called pre-approval, and your doctor can fill out a pre-approval form. If you're purchasing your insulin from a pharmacy, the pharmacy is required to get a pre-approval form from the insurance carrier and then fax that form to your physician for the physician to fill out and justify the switch to Tresiba. And what he, or Tresiba or Levemir, and what you could ask the physician to do is write down that the Lantus burns you and is very uncomfortable and discourages you from taking insulin. How do I become your patient? By video or in person? Right now, with the COVID epidemic, all my patients are communicating with me by Skype or telephone, and they email or fax their blood sugar data. Ordinarily, prior to the epidemic, patients came from all over the world, so I was obliged to invent telemedicine when I started in practice in 1983 or 84. But people would come into my office for 3 days so that I could examine them, take a history, negotiate a meal plan up front. Actually, in those days was maybe even 4 days in a row. And then they'd go back home, but they would send their blood sugar data to me. And we've been doing that up until this epidemic began. Now I'll see a new patient, I'll get on Skype, I'll get lengthy history forms that he fills out, and then I take a verbal history on top of that that takes anywhere from 1 hour for most children up to maybe 4 hours or even longer for an elderly person who has many ailments and a long family history, etc. I can't do a physical exam, but my new patients have promised to come in once the epidemic is over so that I can do an exam for diabetic complications. In the meanwhile, they send me a physical exam by their own physician. And I will not treat anybody who has not read my book, Diabetes Solution, for the simple reason that I do training on Skype or on the phone, and the training would take a year if the patient hadn't read my book. Also, I want them to know in advance that it's a tough regimen and they may not want it. So why should why should I start treating a patient who's going to balk at all the things I ask him to do? So we won't even book a patient or discuss details if they haven't read the book. When eating ground beef with some cheese or any other heavier, fatter meal, to give 4 to 5 units of regular to cover protein and after 3 to 4 hours. However, with these doses, usually goes low in the first 2 hours. Well, first of all, I'd ask this person to read my book because the question is covered in the book. There are a number of things that you could do. First of all, it depends on the length of time between the shot, let's say you're taking regular insulin, and the start of the meal. The longer the time delay between the shot and the meal, the lower you're going to go early on. So in people with gastroparesis whose digestion is too slow, we may have them take the shot immediately at the start of the meal, or even halfway through, or in extreme cases, an hour after the meal. In other people with gastroparesis, we may mix NPH insulin with the regular insulin, usually a small amount. Maybe we might have 90% regular insulin and 10% NPH. The NPH will slow down the action of the regular insulin. By the way, I might as well mention that there's a myth associated with NPH. When it was originally developed when I was a kid, they told us that if you mix NPH with regular, you'll get the effect of both insulins as if there were two separate shots. And that was an absolute lie. Didn't realize it until I got a blood sugar meter and started measuring my blood sugars, and saw that the new mixture acted like it was a new insulin in between regular and NPH. And this is what happens when you add a little bit of NPH to the regular for a meal. You slow down the regular, and you have an insulin that's going to work longer. According to many nutritionists, the correct way to count carbohydrates in foods with dietary fiber is to subtract half of the dietary fiber from the total carbohydrates. Their reasoning behind this is that most foods are composed of half soluble fiber and half insoluble fiber. Is this method valid? If so, is it all a one size fits all? Well, first of all, I had a lot of experience with nutritionists when I was a medical student and in postgraduate training, where I had to manage patients in the hospitals. And I met many nutritionists because they rotated us through a number of hospitals. And every nutritionist I encountered was grossly overweight. So just on that basis, you have to give second thought to what nutritionists tell you. And in my experience, and here what they're telling this person apparently is eat different amounts of carbohydrate at different meals, different days, and just try to estimate the amount of carbohydrate in your meals to adjust insulin doses. And carbohydrate is the only food component that affects blood sugar. And all of this is incorrect. First of all, protein and fat, and even the bulk of a meal, that is how much it weighs or what volume it occupies, all these affect blood sugar. So you can estimate the carbohydrate part, but you're never going to get it exact. And the only way to be reasonably precise would be to have the same meal day after day. So the same breakfast today, tomorrow, and the next day, the same lunch today. And once you deviate from that, even if you have the same percentage of protein, fat, and carbohydrate, they're gonna be changes, because just the sheer density or volume that it occupies affects blood sugar. So the only way to be sure is to have the same thing every day. And just looking at carbohydrate is looking at a small piece of the total, unless, of course, you're following an ADA diet and it's a big piece. So you can take half the fiber, and it's not because of soluble and insoluble. It's because it takes more energy provided by glucose to break down fiber. And that can be an initial estimate for a particular meal, but if you don't duplicate that meal, you're not going to get the same results. And if you're only looking at carbohydrate, you're not going to control your blood sugars. Is sleep apnea caused by elevated blood glucose / diabetic complications related to autonomic neuropathy? I just discovered that I have sleep apnea. Not to my knowledge, but it's a possibility. First of all, as I understand it from reading the literature, sleep apnea is most common in overweight people, usually grossly overweight people. Also, it's usually associated with a thickened, soft palate. So it has something to do with the anatomy of the mouth. Now, what can be done for the sleep apnea? There are specialists in sleep apnea. There are sleep laboratories. There are all kinds of tests that measure your breathing at night. So I'm sure you've researched this. Does it have to do with, is this a diabetic complication? I don't think so, but the specialists in sleep apnea might know better. They could check you for autonomic neuropathy by doing an RR interval study. I am a fit and active 51-year-old type 1 diabetic who, thanks to you, has kept his A1C below 5% for the past 7 years. I guess he's read my book, or she. However, my last A1C was 5.4%, even though my BG meter, which usually matches my A1C, indicated otherwise, indicated close to 4.6%. This test closely followed a bout of food poisoning where I was extremely unwell. Can illness such as this adversely affect A1C and make them appear higher than they actually are? Well, if the food poisoning or whatever the illness was affects the lifespan of red blood cells, for example, if it caused B12 or folate malabsorption, which if you don't get enough of those vitamins, you might be anemic. And there's a macrocytic anemia where the red blood cells live longer, but you don't make as many. And by living longer, the hemoglobin absorbs more glucose, and you can get a higher A1C. So if you've developed macrocytic anemia, there's a possibility that indeed your A1Cs for a period of maybe 4 months might not match your blood sugars. And then, of course, you'd have to check B12 and folate, the size of the red blood cells, and it's tough to get accurate measurements of vitamin B12, but you can, by implication, also check homocysteine and methylmalonic acid in the blood, which go up when B12 is too low. I am from India. I got to know I have type 2 diabetes this week. I was born overweight and my mother had diabetes during pregnancy. Now my A1C is 10.6, and that's probably over an average blood sugar over 300 milligrams per deciliter. And fasting sugar is 216. I've yet to take medication. Should I avoid doing exercise in the morning? And what is the time to do exercise? And is there any chance of type 2 reversal? Well, right now, my guess is that you probably should be taking insulin. You probably should be on a very low carbohydrate diet, both for losing weight and for keeping blood sugars down. You should be following my book. And while your blood sugars are this high, you probably should not be exercising. More likely to exercise when you get them down, because what we found is that people who exercise when their blood sugars are high, they don't have enough insulin, the blood sugars go higher. So it's likely that your blood sugars would go higher when you exercise. It's not going to be a treatment for your diabetes if your blood sugars are so high. The exercise is not so powerful that it can get a blood sugar of 300 down to normal. That's my guess. You might want to talk to some physicians. Hello, I'm a type 1 patient from Romania. Following your book guidelines, have you used metformin besides insulin in type 1 patient treatments? And if so, what are the pros and cons? Also, thank you for all your work. Yes, I have used metformin. I use it a lot in children who have insulin resistance due to hormonal changes during puberty, and also due to growth hormone. It seems to make a difference. In fact, thanks to a young lady, an observant young lady, I was giving her multi-dose insulin according to the guidelines in my book. She was getting basal bolus insulin, etc., following a low carbohydrate diet. And because she was experiencing early puberty and her blood sugars were going up, I put her on metformin. Blood sugars came down, and the pharmacy switched manufacturers of metformin. All of a sudden, her blood sugars are up, maybe starting several days later, and over the next week or two, blood sugars getting higher and higher. We didn't know what was, excuse me, we didn't know what was going on. Then she observed unopened whole metformin capsules in her stool. So the metformin capsules were not even dissolving in her stomach. She had a brand where the capsules were insoluble. The metformin was not getting into the patient's bloodstream. Must have been happening to tens of thousands of patients, and no one was reporting it, and no one noticed it because probably it was only being used for type 2 patients, and most type 2 patients were not measuring their blood sugars. In fact, as I recall, the powers that be don't recommend blood sugar measurements by type 2 patients. So here we have a manufacturer selling worthless metformin, and no one knows it. Well, that's it for April 2021. Our May 2021 session will be released on Wednesday, May 26th, and the May session will be available for an indefinite, extended period of time thereafter. Thanks so much for watching or listening.